Let's just face it, the head and neck section of your board prep is an absolute beast. It is literally a mountain of data, complex anatomy, and constantly evolving clinical trials. But hey, don't worry, because that's exactly why we're here today. In this explainer, we're going to distill all of that down into a fast-paced, high-yield review of the absolute core, board-relevant trials that dictate modern clinical practice. By the end of this, you're going to have the evidence-based ammunition you need to totally crush the clinic and your boards. Okay, let's dive into this. Here is our roadmap for today. We'll be covering 1. Preserving the larynx. 2. HPV-positive oropharyngeal cancer. 3. Nasopharyngeal carcinoma standards. 4. High-yield T-staging rules. And 5. Toxicity, palliation, and innovations.
Pillar 1. Preserving the larynx. From surgical resection to functional organ preservation.
So for decades, the standard treatment for advanced larynx cancer was just a total laryngectomy. But the field embarked on this historic quest to save the voice box. This whole journey really kicked off with the landmark VA larynx trial. This trial basically proved the concept that using induction chemotherapy, followed by radiation, could preserve the larynx in 62% of patients, and crucially, without compromising overall survival compared to upfront surgery. But the real game changer? That came a bit later with RTOG 9111. This was the trial that proved concurrent chemoradiation is the undisputed gold standard. By giving cisplatin concurrently with radiation, the larynx preservation rates jumped up to a massive 88% at 2 years, significantly beating out both induction chemo and radiation alone.
Now, you might be wondering about early-stage disease. Say you're looking at a T1 glottic cancer. You have 2 really great options: transoral laser surgery or definitive radiation. The Altonen and Pockanen trials sought to compare these directly, and what they found is absolutely crucial for your patient consultations. Oncologically speaking, survival is statistically identical, no difference. However, from a functional perspective, objective expert voice assessments actually favor radiation, especially for those anterior lesions. The surgery just resulted in a bit more breathiness and irregular glottal closure. So the big takeaway here is that treatment must be highly individualized based on the patient's specific anatomy and their vocal priorities.
Pillar 2. The HPV-positive oropharynx paradigm. The distinct biological disease and the de-escalation debate.
The rise of HPV-positive oropharyngeal squamous cell carcinoma completely shifted our entire landscape. We realized pretty quickly that we were dealing with a completely distinct biological entity that responds phenomenally well to treatment. And because these patients live a really long time, the late toxicities of 70 gray of radiation plus high-dose cisplatin become a huge survivorship issue. So, this burning clinical controversy emerged. Could we de-escalate treatment? Like, could we just swap out the harsh cisplatin for the targeted EGFR inhibitor, cetuximab, and spare these patients the severe toxicity?
Well, the data definitively answered that question. Now, what's really interesting about this slide is how clear the answer is. 2 major phase 3 trials, RTOG 1016 over in the US and de-escalate in the UK, tested this exact hypothesis. And the results? Honestly, they were stunning. In both trials, cetuximab was associated with a near doubling of local regional failure rates and significantly worse 5-year overall survival. So it turns out substituting cetuximab isn't just less effective, it is downright dangerous for disease control. Cisplatin remains the superior choice.
Okay, so what about de-escalating the radiation dose itself? NRG-HN002 was a phase 2 trial that gave us a lot of hope. It showed that lowering the dose to 60 gray with concurrent cisplatin actually met acceptable progression-free survival criteria. But when they tried to validate this in the phase 3 NRG-HN005 trial, comparing that de-escalated 60 gray directly against the standard 70 gray, it actually closed early for futility. The de-escalated arm simply could not match the 98% progression-free survival of the 70 gray arm. So for now, 70 gray plus cisplatin remains the absolute benchmark. No shortcuts just yet.
Pillar 3. Nasopharyngeal carcinoma standards. The evolution of systemic therapy in NPC.
Now, this disease is incredibly unique because it's so highly driven by EBV in endemic regions, and it has a massive propensity for systemic spread. Let's move to ANSI and see how this standard of care actually built chronologically. Back in 1998, the Intergroup 0099 trial established concurrent chemoradiation as the standard over radiation alone. Fast forward to 2009, RTOG 0225 validated IMRT, proving we could finally spare the parotids and deliver high doses to the skull base safely. But the real systemic leap? That happened recently in 2019 with the Zhang trial in the New England Journal of Medicine.
Which brings us to this absolutely essential clinical pearl. The ZONG trial proved that giving induction chemotherapy with gemcitabine and cisplatin right before standard chemoradiation massively reduced distant metastases. We're talking an improvement in 3-year overall survival from 90% to nearly 95%. This basically cemented induction chemo followed by concurrent CRT as the undisputed modern standard for local regionally advanced NPC.
Pillar 4. High-Yield T-Staging Rules. Navigating the AJCC 8th edition.
All right, let's shift gears for a second and do some rapid-fire anatomy. Because when you're contouring for your attendings or sitting for your board exams, the nuances of the AJC 8th edition will literally make or break you. Maxillary sinus staging is a classic testing ground. Notice how specific the bony boundaries are here. A T1 is completely limited to the sinus. Once you have bone erosion into the hard palate or middle meatus, boom, it's T2. But, and this is a really big but, if it hits that posterior wall, it jumps straight to a T3. T4A involves the anterior orbit or pterygoid plates. And T4B? That means the tumor has hit critical real estate, the orbital apex, dura, brain, or cranial nerves other than V2. Memorize these boundaries. They come up all the time.
Next up, cutaneous squamous cell carcinoma. You absolutely must know the exact millimeter metrics that define a T3 tumor, because these are the high-risk features that actually prompt adjuvant radiation recommendations. So a T3 requires a tumor over 4 centimeters, or deep invasion defined as strictly greater than 6 millimeters, or paraneural invasion of a nerve that is 0.1 millimeters or larger. If you see gross cortical bone invasion, you are at T4A, and if it's hitting the skull base, or foramen, that pushes it all the way to T4B.
Pillar 5. Toxicity, palliation, and innovations. Navigating the late effects and the future of RT.
For our final pillar, we have to talk about the harsh reality of head and neck radiotherapy, which is the toxicity. As our patients are living longer, the late effects of our treatments are becoming central to their care. 70%. I want that number to really stick in your head. Based on massive retrospective data from Arthurs and colleagues, patients who receive head and neck radiation alone have a 70% increased risk of experiencing a stroke compared to those who just undergo surgery alone. We are actively accelerating carotid atherosclerosis, and we have to be counseling our patients on these long-term cardiovascular risk factors.
So the crucial point is this. When a patient recurs and you're sitting there considering reirradiation, you must respect the carotids. Reirradiation carries a small but literally catastrophic risk of carotid blowout syndrome. We're talking rapid, often fatal hemorrhage. Guidelines now strongly dictate that to balance tumor control against vascular injury, your cumulative lifetime dose to that carotid artery must be strictly kept under 120 to 125 gray. No exceptions.
But hey, what if your patient recurs? They have a poor performance status and they just aren't a candidate for standard reirradiation? Enter the quad shot. This is a brilliant palliative regimen. It's 3.7 gray delivered twice a day for just 2 days. That gives you 14.8 gray per course, which you then repeat every 3 weeks for up to 3 courses. It has an incredible 77% objective response rate. It melts away fungating tumors, stops bleeding, and it does all of this with virtually 0 major late toxicities. A real game changer for palliation.
And this brilliantly illustrates exactly where our field is heading next to combat these toxicities. Check out this recent 2026 Phase 3 trial. It directly compared proton therapy, or IMPT, against standard photon IMRT for oropharyngeal cancer. Not only did proton significantly reduce 60-day feeding tube dependence all the way down to 26.8%, but astonishingly, it demonstrated a 5-year overall survival benefit. We're talking 90.9% for protons versus 81% for photons. By sparing the uninvolved normal tissue and the immune cells, we aren't just reducing side effects anymore. We might actually be helping these patients live significantly longer.
Which brings us right to the end of our explainer and leaves us with a pretty massive question to ponder. With protons now showing a legitimate survival edge and immunotherapy combinations totally transforming the systemic landscape, the algorithms you are memorizing right now, they're just a stepping stone. What will the standard of care for head and neck cancer actually look like when you finally sign on as attending physicians? Keep digging into the data, keep questioning the standards, and best of luck on those boards.